Hi everyone, my name is Ren. Thanks for the introduction, Sohini. So I'm one of the radiology ST2 based in Southampton at the moment. So today I'll be talking about the fundamental principle of intervention radiology. First of all, I'll start with just talking about the basic vascular anatomy and now focus mainly on the neck vessels and the femoral vessels because that's where we do most of the punctures in IR. And after we gain some basic knowledge of the vascular anatomy, I'll talk about how do we actually gain access into the vein or the artery. And then I'll show you a pictures of what a typical intervention radiology theater looks like. And I talk you through all like the different parts and components within it. And then last but not least, I'll briefly run past like commonly used sheath wires and catheters in IR. So we start with the vascular anatomy in the neck. So on the left of your screen, you can see sort of a very nice illustrative pictures demonstrating the common carotid artery, so in the red here, and the internal jugular vein in blue. And you have the other structures within your neck as well. So in the middle, have your airway, your trachea, and the esophagus behind it. Obviously, you have your thyroid lobes as well, and the other neck muscles, either anterior and posterior, and some of the fats around. And if you imagine, if you put an ultrasound probe on this area of the neck perpendicular to the vessels, you will get a transverse view of all the neck vessels and the surrounding organ. And it will translate into these pictures here on your right hand side. So obviously, we are mainly looking at the common carotid artery and the internal jugular vein. And there's some useful tips and tricks to differentiate which one is the artery and which one is the vein. And usually the artery is medial to the vein, but that can be misleading at times depending how you position the probe and the patient's position as well. So other methods to differentiate is, as we all remember from medical school, the arterial wall is stronger and more elastic than the vein, so it always most likely appear to be like rounded, whereas the vein is not. And the other more reliable method is, because ultrasound is a dynamic study, if you're ever in doubt, you just have to gently put a bit more pressure on the patient's neck. And then what you notice is the vein will sort of like collapses, whereas the artery will remain open. Hopefully that makes it clear. And then obviously when we are doing the puncture, we don't really need to see sort of like the thyroid or all this like neck muscle at the back. What we want is just the vessel as big as possible right in the middle of the screen, somewhere like this. So that's the common carotid artery because it's in the medial side, as like demonstrated on this picture here, and that's the internal jugular vein on the lateral. And again, if you're ever in doubt, just put some pressure of the probe on the patient's skins and the vein should collapse nicely and the artery will remain open. And usually when you do the puncture, the needle, on this view, the needle will come somewhere from here in this direction. And then when you visualize the tip of the needle, you just have to puncture into the vein and then you gain access into the vein. And now we shall move on to the anatomy in the femoral vessels. So once again, the illustrative pictures, the head of the femur is right in the middle, and you have lots of different muscles in different compartments of the thighs, and we are focusing on the vessels and the nerve. So there's lots of way to remember the orientation of the vessels or the vein. The one that I remember from medical school is the mnemonic VAN, so VAN, coming from medial to lateral, so it's the vein, artery, and nerve. And now, if you imagine we put the ultrasound probe on the patient's skin, once again perpendicular to the vessel. So the transverse view, this is what we get. So we have the artery, a bit more rounded than the common femoral vein, looks a bit flatter. And always, if ever in doubt, put a bit gentle pressure on and the vein collapses and the artery will remain open. And now this is a long axis view or a longitudinal view of the common femoral artery. So if you imagine initially where the probe is perpendicular to the vessel, now if you rotate the probe 90 degrees so that the probe is parallel to the vessel, and this is the view you will get, like an elongated view of the artery. So that's the common femoral artery, and then it will branch into a superficial branch and a deep branch. The superficial branch being the superficial femoral artery, and the deep branch would be the profunda femoris artery. And where we usually do the puncture in IR, we tend to puncture the common femoral artery. And what we want on the image is we want to have the head of the femur somewhere behind it as well. Because if you imagine you coming through with the needle here, where you want to puncture the CFA just around here, what you want is a very solid platform on the back. So that would be the head of the femur. So that it's easier for you to puncture because it's provide lots of extra support and stability when you try to do the puncture. Different operators has different methods of puncturing the CFA. Some of the consultants prefer to first of all put it into the long axis view, guide the needle to somewhere around here, just above the femoral head, and then they'll go back to the transverse view and try to get the needle right in the middle of the artery before they puncture into it. Some consultants prefer to do everything in just a transverse view, but that takes a bit of time to get used to, where you have to keep panning the probe towards the head or towards the toe to try to find the tip of the needle and then puncture the artery from there. And whereas some consultants prefer to do the whole do the whole puncture just on the long axis view. Every method is safe as long as you can visualize the artery and visualize the tip of the needle so that you know where you are going and not damaging the surrounding structures. Intervention cardiology, they like to use the radial artery as their site of puncture. In IR, we very rarely use the radial artery. That's because mainly it's smaller compared to the common femoral artery, but sometimes we do use them if needed. Now that we have some knowledge on the vascular anatomy, I'll talk about how do we actually gain access into the vessels. So now basically this the Seldinger technique is the most widely used technique to get into the vessels, and it's created or pioneered by Dr. Seldinger, a Swedish radiology consultant back in the 1950s, and now it's the most widely technique used in the world. So to do this, first of all, you need to puncture the desired vessels, or it could be either like a fluid collection or a cavity. So for example, it could be like an intra-abdominal abscess or like a liver abscess, or sometimes if the patient has like hydronephrosis, you want to put a nephrostomy into the kidney. That's all part of like Seldinger technique as well. So you have to puncture into the lumen with a needle. And once the needle is in place, depending what you are puncturing, if it's in the artery, you have blood squirting out. And if it's a vein, then you might have just a bit of blood oozing out. And if it's like an abscess, you might have pus coming out. And immediately, once you gain access into the lumen, you pass a wire through the needle and push it into the lumen. And once the wire is in, you have to apply forward pressure on the wire while pulling the needle back. And then you can remove the needle over the wire. And while keeping the wire steady in place, you then pass either a sheath or a catheter over the wire into the lumen. And once the sheath is in, you can just withdraw the wire altogether. And with the sheath in situ, you will have secure access to the vessels. And this is just like a diagram to illustrate the Seldinger technique again. So once again, starting from the top left, you have a needle into the lumen, and then immediately after that, you pass a wire through the needle into the lumen. And then while the wire is in, you can withdraw the needle. And usually because the needle is a very small caliber needle, so you need to make like a small incision on the skin enable for you to pass a bigger catheter through the skin into the lumen. And then you pass the catheter over the wire into the lumen, and once the catheter is in, you can withdraw the wire, and now you have a secure access. And there's two, in terms of like vascular access, there's two main type of puncture. One is called antegrade puncture, and the other is called retrograde puncture. And to make this simple, it's basically the direction of the sheath or the catheter in relation to the direction of the blood flow. So in this diagram here, we are puncturing the common femoral artery, so it's arterial puncture. So let's look at C first. So on C, the direction of the sheath is along with the direction of the blood flow, sort of like towards the leg. So it's an antegrade puncture because it's with the flow of the blood. Whereas in diagram A, the sheath is pointing away from the leg, so like towards the heart. So it's against the blood flow in the artery. So it's a retrograde puncture. So if you imagine if you're puncturing the vein, it's just the other way around. But the basic principle is always the same. It's always in relation with the direction of the blood flow. And this is a picture I took last week of the intervention radiology theatre in Southampton. So this picture looks a bit busy. There's lots of things going on here, and I'll break it down for you. So right in the middle of the screen here, that's the table where the patient will lie on. So the patient head can either be on this end or it can be on this end. And as you can see here, this bit here, it will allow the table to be moved up or down. And one other movement the table can do is to tilt the table so that the patient heads move like towards this, move up sort of like this way, or the patient heads will move down this way. And then you have like right in the middle, this fluoro machine. This is what we call a C-arm. So the C-arm can be either one of two. They can be either a ceiling mounted C-arm like the one in this picture, or they can be a floor mounted C-arm where this bit here, instead of like being attached to the ceiling, it will be attached to the floor. And then this is the actual X-ray machine. So this is the machine that generates the X-rays, and it will leave the X-ray machine, pass through the patient, hit the detector, and that's how you get the X-rays or the fluoro image. And the C-arm itself, it's got a field movement. And so if you can see this, that's the railing on the ceiling, and this whole machine can either move to this direction or this direction, depending which part of the body you want to image. And then this C-arm itself, it can rotate 360 degrees. And then if I bring attention to this bit here, so the whole thing can be tilted once again either towards the patient head or towards the patient's feet to give you a bit more angulation to sometimes to open up the images. And then hiding in the background there, that's just like a big screen to show like the live pictures of the X-rays and the fluoro to guide the treatment or the procedure. And then this bit there in the background, there's a pump injector. So usually we fill that up with contrast and we can connect it to the catheter, and it will allow the contrast to be pumped through at a much higher pressure than what like it's humanly possible to achieve by pushing down the contrast in a syringe. And usually that will give you a much better angiogram. You can see there's lots of sort of like tiny little controls that's used by the radiographer to control either the X-rays machine or the C-arm as well during the procedure. I just want to sort of like quickly talk through who's usually involved in like an IR case. So obviously there will be a consultant or registrar as the first operator. And then depending on the complexity of the case, he or she might have either one or two assistants. And in big cases like an EVA, it's very common to have two assistants. Obviously, you need to have a scrub nurse as well. And once again, depending on the complexity, sometimes you can have up to two scrub nurses. And you will have a radiographer in the room as well, and they would be the ones sort of like dealing with the control of the C-arm and change the setting of the X-rays to let you optimize the image that you are taking. Apart from the scrub nurse, there's going to be other IR nurses in the room as well. Generally, there will be at least two other. One will be in charge of monitoring the patient's vital signs during the procedure, so that's the ops machine there. And the other IR nurse would be basically a runner to get sort of like equipment like catheter, different types of wire, sheath, stand, balloons from like either from the cupboard in the room, or sometimes they might have to even go to like a specific cupboard or other rooms to get like very specific equipment for the procedure. The latch shield, so when they're actually doing the case, this would be pulled out. So basically to protect the first operator from excessive radiation. I thought it would be useful for me to talk through sort of like this slide here, because before I went into IR, This is all very confusing to me. So hopefully I'll be able to make it a bit simpler for you guys to understand so that it will be less confusing for you if you step foot in the IR theater one day. So the diameter of the needle is measured in gauge. And the confusing bit is the lower the gauge, the larger the needle. And one good example is, if I'm sure we've all been asked to do like cannulas on patient. A blue cannula is 22 gauge and the green cannula is 18 gauge, where it makes your heart beats a bit faster when you need to put the green cannula in a patient. Well, at least that's what I always feel like. So that kind of like makes sense because a green cannula is 18 gauge, it's bigger than the blue cannula 22 gauge. So that's kind of like how I remember. And catheter and sheath, they are measured in French unit, so short for either FR or just F. And one French is equivalent to 1/3 of a millimeter. Whereas the wire diameter, they are measured in inches. So the commonly used like 018 or 035 wire basically just mean they are 0.018 inch in diameter or 0.035 inch. And now I'll move on to talk about the sheath. On this picture here, right in the middle, the white bit, that's the sheath itself. And then the one on the bottom, the pink bit, that's the dilator. So you might notice the dilator is much longer than the sheath itself, and it has a purpose for that. So to assemble, they all comes like sort of like separately like this, and for you to assemble, you will need to put the dilator through the sheath itself. So that if you imagine when this being put through the sheath, the this tip here would lie somewhere like here. And that's because when you puncture the skin into the vessels, the needle is quite small and the wire is even smaller because it passes through the needle. And then after that, I'm not sure if you remember from the diagram earlier, you need to make a small skin incision before you pass the sheath and the dilator in. Hopefully what the dilator does is because the tip is quite sharp, not sharp, like sort of like narrow, and gradually go back up to sort of like the bigger bit in the middle. So hopefully that will sort of like create like a tunnel or like a path through the soft tissue into the vessels without causing too much damage. So that's the idea of like the dilator. And sometimes when you need to upsize your sheath, you need to put like a bigger dilator to like dilate the tract before you can put the bigger sheath through the tract, or else you might cause lots of like a bleeding, hematoma in the soft tissue, or even worse, like a dissect the vessels. One tip in IR is you always flush everything before you use them. So you need to flush the sheath, you need to flush the dilator. Once you assemble your sheath, you can just put the sheath through the wire into the vessels, and then you can remove the wire after that, and then the sheath will provide a secure access. And one confusing thing about sheath and catheter, which I'll explain a bit further when I talk about the catheter. So just remember for now, the sheath French size is the measure of its inner diameter. Okay, and I'll talk about the catheter a bit later. To select the sheath size is basically based on what are we trying to do with the procedure. So for example, if we're just doing a diagnostic angiogram, 4 French sheath is more than enough, versus if we're doing like either a stent or angioplasty or ballooning, then we might need either a size 5 or 6 French. Versus a EVA, then definitely we need at least a size like 9 French or even 10. And that, yeah, as I mentioned earlier, the sheath main function is to provide support and control access into the lumen, where you can exchange different type of wire, catheter, etc. And depending on the shape of the vessel, they can either be curved or straight. Most of the time, we can get away with a straight sheath. This is basically to demonstrate the size of the sheath. They are color coded universally. So you don't have to remember what color is what size French sheath. They should all always be clearly written on the packaging anyway. But the more you use them sort of like on a day-to-day basis, this will just become like a second nature. Right, so now I'll move on to talk about wires. There's 3 main properties that determine the function of the wires in IR. One is the diameter. And as I briefly touched on earlier, the most commonly diameter is 018 or 035. And on the smaller end of the spectrum, you have like the 014 as like a micro wire, or you have like a slightly bigger wire like 038. They have different stiffness as well. So stiffness and steerability kind of go like hands in hand, because you can't have both stiffness and steerability. It's kind of like a cut-off between the two of them. So a very stiff wire has very little steerability, as in it's quite difficult to maneuver the wire into like tiny vessels like you want. On the other hand, a floppy wire has excellent steerability. And then last but not least, the coating of the wire itself is one of the main properties as well. And usually they can come in either hydrophilic or non-hydrophilic composition. So hydrophilic basically just means they like water, and they are very useful in the fluid environment, like in the blood vessels. They are like less resistant. They're generally quite, they can be quite floppy. They can get to sort of like small vessels. One thing to note that they are quite slippery. Be careful not to drop the wire on the floor. But at the same time, when they are dry, they can be very sticky. So it's always, you have to flush like any hydrophilic wire before you stick them into a catheter or a sheath, because if you stick them in when they are dry, they can get stuck to the sheath or the catheter, and that wouldn't be pleasant. And non-hydrophilic wire, on the other hand, it's much easier to grip, and they usually can provide more resistance or stability. And then there's, based on the property, then there's three basic type of wires. Excess wire, they usually are quite short, so sort of like 40 to 60 centimeters. And we only use them usually right in the beginning after we puncture the vessels. We put like a short excess wire in, so that's easier for you to remove the wire and put the sheath in immediately. Maneuver wire would be a good example of quite a floppy wire with hydrophilic, and the tip is often like curved, and they are useful to try to get into like tiny vessels. On the other hand, you would have a real wire. So real wire is usually very stiff, and they could be either hydrophilic or non-hydrophilic. And usually it's sort of like a cutoff. It's very stiff, it's stable, but it doesn't have very good like steerability. But that doesn't matter, because all we want is a very stable wire for us to exchange either like a long catheter or do the angioplasty or deploy the stent. So this table looks quite basic, but it's basically nicely demonstrate the three main properties of the wire and lots of different types of wire based on those properties. So on this side of the screen, you have the 018 wire, like the 018 diameter 035, and then you have either the hydrophilic or non-hydrophilic. And then this is like sort of like the stiffness gradient of it. This is like stiff and this is floppy. And the most commonly wire you would hear sort of like being talked about in IR room is a glide wire, or the brand name is called Terumo. Or a Benson wire is quite useful in angioplasty. Amplex is used quite a lot as well, Lundquist. And this is just a picture of a Terumo wire. So they usually come in sterile packaging like this, and the wire is basically in sort of like this plastic case over here. So this would be the tip of the wire, and this end here, this is basically a bung for you to insert the syringe on. Usually this is how you flush the needle initially. When you take it out from the package, you just fill the syringe with like saline, you attach the syringe to this end, you give it a good flush, and when there's saline coming out from this end, you know the wire is flush and ready to use. And all the information you need would be on the packaging as well. So this is straight, it's a 035 diameter. The total length of the wire is 150 centimeters. And always check for the expiry date as well. And another different type of wire, so this is the Amplex super stiff. So this is an example of a real wire. So once again, all the information should be on the packaging. It's 035 diameter, and this is a bit longer, 260 centimeters. So I thought it'd be interesting to show some of the real life pictures from the fluoro on how the wire looks like. So this is a femur, and that's the inferior pubic ramus. So if you imagine the head of the femur is somewhere around here, and this is where they puncture the CFA. So as a quick recap from previously, this would be an anti-grade puncture, because that's the tip of the sheath there, like the bit with sort of like a darker bit. So it's like in along with the blood flow in the artery. So that's the antegrade puncture. And all like the different clips and stuff you can see further down in the media aspect of the thigh. That's just the previous surgical clip from bypass. And like the black fluffy stuff is just the calcification in the vessels. And obviously the patient has some peripheral artery disease. That's why he's having this angioplasty. And so this would be the wire. So this would be a Benson wire. So they're usually nice and straight, and the consultant would try to get past the stenosis by using this wire. Okay. And this is a different type of wire being used here. So as you can see the pelvis here. And instead of one sheath, there's two sheaths. So they puncture both of the CFA. And this time, the sheath is in the opposite direction of the blood flow. So this would be a bilateral CFA retrograde puncture. And I'm not sure how well is this projecting on the screen, but can you see there is a stent there? So they have already deployed a stent in the left common iliac artery. And then you can see they put like two wires through the sheath into the aorta. And I'll just quickly jump back to the previous study. So if you remember sort of like how thick the wire here looks compared to this obviously is a much thinner wire. So this is like a maneuver wire where they try to get down to the vessel. Well, now they are deploying the stent. They are going to put the balloons up. So they want like a rail wire, something very stable for them to do the treatment. And now I talk about the catheters. So both sheath and catheters, they are measured in French size. French size. But previously I mentioned the sheath is the measure of the inner diameter, whereas the catheter is a measure of its outer diameter. And this is because if you imagine you need to pass the catheter through the sheath, and a full French catheter should be able to fit into a full French sheath. So the catheter technically should be slightly smaller than the sheath. So that's why the catheter measure of its outer, whereas the sheath is measure of its inner diameter. And the catheter has lots of function. Some of the function would be injection, so you can inject contrast through it. Or it could be to deliver embolization, either a coils or glues, or ballooning, like angioplasty, deploying the stent, or even retrieving and deploying devices. And one of the most common procedure that we do is IVC filter, either insertion or removal. There's loads of different types of catheter, but I would try to describe a few based on their different characteristic. This is a pigtail catheter. It's called a pigtail catheter because it shapes like a pigtail. Pigtail catheter has lots of side hole here, and so they are quite useful like in this case. So that's the IVC filter that I was talking earlier. This is a pigtail catheter in the inferior vena cava. And on the outside, this would be connected to the pump injector again. So they would inject the contrast at high pressure to get a very nice venogram because they want to delineate where's the renal vein. High pressure contrast coming out from the side holes to opacify the vena cava very nicely. Because if you imagine without the side hole, if all the contrast were just to come out from like this, it wouldn't be a very nice picture. And then this is just to demonstrate even like a similar like pigtail catheter has lots of like different function. So previously we see a pigtail catheter being used in the IVC, but here we are seeing the pigtail catheter being used to drain a liver abscess. So that's the background, like normal liver. That's the big abscess there. And this is what the pigtail catheter looks like on ultrasound. So previously, like all the side holes like here would be just draining all the abscess. This is slide is basically to show there's lots of different types of catheter that lots of different types of catheter in IR, and they're all slightly different because the shape of the tips is different, and we need like lots of like different shapes of catheter because the human anatomy, the vessels, they're all slightly different. They're not all the same, so you need a different shaped catheter to try to get into different vessels, basically. And now I thought I would to talk a bit more about this Simmons catheter or a Sims catheter. They're commonly used to sort of like get access into the celiac axis, the superior mesenteric artery or inferior mesenteric artery. So this is what the Sims catheter look like. So it's got this like double curve. So one curve over here and one curve over there. So I can't actually find any pictures of a Sims catheter being used. So you just have to bear with my horrible drawing. So if you imagine, this is the abdominal aorta, and this is your celiac axis, and this is your SMA. So if you imagine, without this Sims catheter, it would be almost near impossible for you to pass when you puncture the CFA, to pass a catheter up here and to try to get into this celiac axis or SMA at an angle. So that's why they have this type of specific catheter, a Sims catheter. So if you imagine, what they do during the procedure is they form this Sims catheter within the aorta. They push it up, past the SMA, and then they gently pull it down. And what they're trying to do is hopefully this tip of the catheter will get hinged onto the celiac axis. And then when they felt that it's hinged onto either the celiac or SMA, they do a quick flush of contrast just to make sure they're in the vessels that they think they are. And then they can just pass a wire which will come out like this into the celiac axis, when then they can push the catheter into it. So just a few more pictures to illustrate different types of catheter, how they use. So in this case, so this is a catheter within the popliteal artery. So this would be an example of a catheter with an end hole rather than side hole like the one in the pigtail catheter, because they don't really need the contrast to come out like from this end. They just want the contrast to go straight down. And obviously this patient has lots of like stenosis here and has lots of like collateralization. But yeah, this is just a good example to show a catheter with end hole. And this is another different type of catheter. So it's only being used like for this like specific procedure. So this is a uterine fibroid embolization. So in IR, we try to keep everything as less invasive as possible for the patient, because as we all know, the uterus has like blood supply from both the left and right internal iliac artery. So in order to embolize a uterine fibroid, it will be futile if you just embolize one side, because the fibroid will just continue to get blood supply from the other side and continue to grow. So they need to embolize both sides. But they don't really want to puncture both groin, and if possible, they would want to just get away with just one puncture. So that's why they have this specific catheter. So it's called a Roberts uterine catheter. So what they do is they just puncture the right CFA. They will get this catheter up and over the aortic bifurcation into the other CIA, embolize the artery on that end, and then when they are done with that side, they just have to pull back the catheter, and then they can do the embolization on the same side where they did the puncture, saving the patient from a double puncture. And this is just to show a microcatheter. So this is quite an interesting case. So the patient had a CT abdomen, which shows that she has a pseudoaneurysm in the splenic artery. So if you imagine that's the catheter sitting in the celiac artery there. That's your common hepatic artery and the GDA going down there. So when they are in the celiac axis, they pass a microcatheter through the existing catheter. All right, so imagine like this picture in the middle. It's just a zoom up version of the pictures on the left. And now you can see this sort of like smaller catheter coming out from the previous catheter. So that's a microcatheter. And then they did the angio on that run, and then they can see this aneurysm, which then they coil. So just to summarize, we touch on basic vascular anatomy, focusing mainly on the neck vessels and the femoral vessels. I talk about the Seldinger technique, how to gain access both into like vessels or in like fluid collection or a cavity, depending on the procedure you are doing. And I show you pictures of what the standard IR theater looks like and all the different components in it. And then I briefly talk about commonly used sheath, wires, and catheters in IR. So thank you all for listening.